Welcome to the e-learning module on pathology of ovarian tumors. In this video, I will be covering epithelial tumors of the ovary, in detail serous and mucinous tumors. I am Dr. Shruti from Pathology Department, KSNJ Medical Academy. The learning objective for this session are to enlist the various epithelial tumors of the ovary, to describe serous and mucinous tumors, and to differentiate benign, borderline, and malignant serous and mucinous tumors. So the contents are classification of the epithelial tumors, pathology of serous and mucinous tumor, and the summary followed by references. So based on the histology, there are three main cell types in the ovary. They are epithelial cells, germ cells, and sex cord stromal cells. So the tumor can arise from each of these three components, and also in addition, there is a fourth set of tumors, which is a metastatic tumor to the ovary. So coming to epithelial tumors, they are the most common type of ovarian tumor which arises from Mullerian epithelium. It accounts for 65 to 70% of all ovarian tumor, and the classification depends on the differentiation of the tumor and also the extent of proliferation of the epithelium. So WHO classifies epithelial tumors of the ovary as serous tumor, mucinous tumor, seromucinous tumor, endometrial tumor, clear cell tumor, Brenner tumor, and other uncommon tumors. So based on the histologic type, there are mainly three types of tumor which are important: serous tumor, mucinous tumor, and endometrial tumor. So in this video, I'll be covering serous and mucinous tumor. Based on the differentiation, each of these epithelial tumor can be subclassified as benign, borderline, and malignant tumor. So in benign tumor, they are further classified based on the component of the tumor. So the component can be cystic or fibrous component. If the tumor is predominantly cystic, they are called as cystadenoma. If it is having both cystic and fibrous component, they are called as cystadenofibroma. If they are predominantly fibrous tumor, they are called as adenofibroma. So benign tumors are the most common epithelial tumor which occur mostly in young women between 20 to 45 years of age group. Whereas borderline tumor are seen slightly at older ages around 40 to 50 age group. Whereas malignant tumors are common in women between 45 to 65 years of age group. Coming to serous tumor. So they are the most common ovarian tumor which accounts for 30% of all ovarian tumor. So 70% of these are benign and 30% of these serous tumors are malignant. So serous tumors can be subclassified as benign, borderline, and malignant. So benign, again based on the cystic and fibrous component. If it is predominantly cystic, it is cystadenoma. If it is predominantly fibrous, it is cystadenofibroma. Borderline tumors are called as serous borderline tumor or atypical proliferative serous tumor. So malignant serous tumors are called as serous carcinoma. So based on the pathogenesis and their atypia, they have been subclassified as low-grade serous carcinoma and high-grade serous. Coming to the pathogenesis of serous ovarian tumor. So various studies have shown that the origin for serous ovarian tumors are fallopian tube epithelium. So during ovulation, there is rupture of ovarian surface epithelium. So as there is fallopian tube which is immediate adjacent to the ovary, the epithelium from the fallopian tube can get implanted through this rupture site over the ovarian surface. So they can get implanted, they can undergo cystic change. So these cysts are called as cortical inclusion cyst. So these inclusion cyst can be the source of serous ovarian tumors. That is why the serous tumor are known to resemble fallopian tube epithelium. So based on the pathogenesis, there are two types of ovarian epithelial tumors: type 1 tumors and type 2 tumors. Type 1 tumors are known to progress from benign that is cystadenoma, to borderline, and then to the malignant tumors. So the tumors which comes under type 1 category are low-grade serous carcinoma, endometrial tumors, and mucinous tumors. So these type 1 tumors are known to be low-grade tumors. They have got good prognosis. The second type, they are type 2 tumors. The origin for type 2 tumor is mainly the implantation from the or inclusion cyst from the fallopian tube epithelium. So the precursor lesion is called as serous tubal intraepithelial carcinoma. So these are called as high grade serous carcinoma, and they are known to have bad prognosis, and they are high grade tumors. Coming to the risk factors. So as such, for malignant serous tumor, the risk factors are not very well known, but in general for epithelial tumors, the risk factors include nulliparity, if there is a strong family history of breast tumors or ovarian tumor or any other type of carcinoma, if the patient has heritable mutation, or higher frequency of carcinoma is seen in patients with low parity. So inherited germ cell mutation in BRCA, BRCA1 and BRCA2 has got increased susceptibility for both ovarian cancer and breast cancer. So whoever has family history of BRCA mutation, they now should undergo preventive surgery, that is salpingo oophorectomy. Before, the preferred surgery was simple oophorectomy, but as we know, based on the pathogenesis, the main source for these serous tumors or any epithelial tumors are the fallopian tube epithelium. So it is always indicated to undergo salpingo oophorectomy rather than simple oophorectomy as a preventive procedure whenever there is family history. So the protective factors are multiparity, later age at menarche, earlier age at menopause, oral contraceptive, or tubal ligation. So if the patient is having multipares, or if there is, it suggests that whenever there is less number of ovulation taking place, there is less chance of ovarian cancer. So coming to serous tumors, so serous tumor, it is more commonly they present with bilateral tumors. So 20% of the benign tumors can be bilateral, 30% of borderline serous tumors or 66% of serous carcinoma can be bilateral. One more characteristic feature is concentric calcification, which is called as Zamoma bodies. So Zamoma bodies are characteristic features of serous tumor, which can be seen in all types like serous, benign tumor, borderline tumor, or malignant carcinoma. So coming to benign serous tumor. So cystadenoma is a predominantly cystic and adenofibroma is a predominantly fibrous tumor. So the size of these tumor can range from 1 centimeter to 30 centimeter. So they can be multicystic or single cyst having clear serous fluid. On histopathology, they will be cyst lined by fallopian tube-like epithelium surrounded by fibrous stroma. So the epithelium will resemble fallopian tube epithelium. So this is a cystadenofibroma which is having predominantly fibrous component. So the prognosis is very good as it is a benign tumor, but it may recur if there is incomplete excision. Coming to borderline serous tumor. So borderline serous tumors are known to be cystic, but they can be partly cystic or partly solid tumor. And the main characteristic feature is presence of papillae, which can be on the surface or which can be within the cyst also. And 1/3 of these cases can be bilateral. On microscopy, we can see hierarchical pattern of papillae, and these papillae will show proliferation of the cells. So there is stratification, that is piling up of the epithelial cells, and minimal nuclear atypia can be seen, but there should not be any stromal invasion. Coming to malignant serous tumor, so they are called as serous carcinoma. Based on the pathogenesis and the extent of nuclear atypia, they can be low-grade serous carcinoma or high-grade serous carcinoma. Low-grade serous carcinoma are having low-grade malignant cytologic atypia, and on imaging, they can be cystic tumor with thick septae or nodular component, which is having increased vascularity. So on gross, there will be multiple papillary growth which can be seen on the surface or it can be within the cyst, and there can be calcification. On microscopy, there will be nests of tumor cells or papillae which is invading the stroma, whereas the cytologic atypia will be low compared to high-grade serous carcinoma. So here we can see there is one gland which is invading the stroma, and this is the zymoma body, which is a concentric calcification, which is characteristic of any serous tumor. So prognosis is excellent. So, but prognosis mainly depends on how much amount of the tumor has been excised in debulking surgery. So the treatment of choice for carcinomas are debulking surgery. If there is more than 2 centimeter residual disease left after surgery, it is associated with poor outcome and they do not respond well to chemotherapy. Coming to high-grade serous carcinoma, so they have epithelial cells displaying papillary, glandular or solid pattern with high-grade nuclear atypia. So the risk factors are mainly the patient who are above 60 years and if there is family history of breast or ovarian cancer. So in genetic profile, it is known to have alteration in P53 mutation, which can be confirmed by immunohistochemistry, and inactivation of BRCA gene can be seen in 50% BRCA1 mutation and 24% BRCA2 mutation. So hereditary predisposition is seen in 50 to 20% of the patient. So that is mainly BRCA mutation. On imaging, it is a large tumor having complex hypervascular pelvic mass, and they can also present with ascites and omental deposit. And usually high-grade serous carcinomas are associated with elevated CA125, which is a serum tumor marker. On gross examination, they can be cystic or solid tumor, but on cut surface, it is a bulky solid tumor with areas of necrosis and hemorrhage. On microscopy, we can see predominantly sheets of tumor cells and also we can see the papillae, but the individual cells will show marked nuclear atypia. So in this picture, we can see marked artery looking atypical cells with a few bizarre tumor cells and they are very hyperchromatic. So prognosis is bad as most of these cases present with widely metastatic disease and the residual tumor after debulking surgery matters for prognosis. So those who are having BRCA mutation have got favorable metastasis compared to spontaneous cases. So to summarize serous tumor, they are multicystic tumor. Benign tumor will have smooth glistening cyst wall with the minimal papillary projection. Borderline tumor will have increased number of papillary projection. Malignant tumor are large bulky tumor with the irregular tumor surface and there will be nodularity on the surface as well. Coming to mucinous tumor are again classified as benign, borderline and malignant tumor. So these mucinous tumors corresponds to 20 to 25% of all ovarian neoplasm and majority of these are benign or borderline tumor. So primary ovarian mucinous carcinomas are very rare. They account for around 30% of all ovarian cancer. So in contrast to serous tumor, mucinous tumor are rarely involving the surface of the tumor, whereas surface involvement is more often seen in serous tumor. So only 5% of mucinous tumors are bilateral, whereas bilaterality is more common in case of serous tumor. And these mucinous tumors are known to produce larger cystic mass and there are reports of tumors which are more than 25 kgs and these are multiloculated tumors with the sticky gelatinous fluid. Coming to benign mucinous tumors, so 95% of these tumors are unilateral and they can be multiloculated having gelatinous fluid. So the mucinous cystadenoma are predominantly cystic tumors which are multiloculated having mucinous deposit within the cyst, whereas adenofibroma are predominantly fibrous tumor having few mucin-filled cysts. So microscopically, there will be cysts which are lined by tall columnar cells which are having apical mucin, and they lack cilia. Cilia will be present in serous tumor, which resembles tubal epithelium. So the borderline mucinous tumors are called whenever there is architectural complexity like stratification of the cells, tuffing of the pattern or papillary pattern, and it should involve more than 10% of the tumor surface. So the main criteria is involvement of more than 10% of the tumor surface. They can show low grade nuclear atypia, but there should not be any stromal invasion. So on microscopy, we can see epithelial stratification, tuffing, and papillary growth pattern. So this is a borderline mucinous tumor which is showing papillary pattern and there is some stratification and low grade nuclear atypia. Coming to mucinous carcinoma, these are invasive tumor having gastrointestinal type of cells. They account for 3 to 4% of ovarian cancer, and they are usually unilateral and they are localized tumors. So on gross, they can be cystic tumor with solid component. On microscopy, there are two histologic patterns, confluent glandular pattern with minimal intervening stroma and infiltrative pattern. So this is the first pattern, which is most common pattern, confluent glandular crowding pattern, where we see papillae or the glands which are closely packed without intervening stroma. The second pattern is infiltrating pattern, where we will be seeing tumor cells which are invading the desmoplastic stroma. So these are the stromal component which is infiltrated by the tumor cells. So the main DD for mucinous carcinoma is metastatic tumors, because the mucinous carcinoma are rare in ovary. So prognosis is mainly depending upon the stage. Most of these tumors are stage 1 when presenting, so they have got favorable prognosis, but it is really important to rule out metastatic tumor. So coming to next entity, which is a clinical condition called as pseudomyxoma peritoni. So this is characterized by mucinous ascites with the presence of cystic epithelial implant on the peritoneal surface, presence of adhesion and frequent involvement of the ovaries. So if extensive, they can produce intestinal obstruction. So why it is important is historically thought that the origin of these tumor is mainly primary ovarian mucinous carcinoma. But recent evidence has proven that almost all of these cases are because of extra ovarian tumor, usually appendix. So majority of the primary mucinous carcinomas are unilateral. So whenever the patient present with bilateral mucinous carcinoma, we need to rule out metastasis from non-ovarian tumor, predominantly appendix or GIT. So to summarize, serous tumor resemble tubal epithelium with presence of cilia. So the origin for serous tumor is mainly the cortical inclusion cyst from the fallopian tube. They are categorized as benign, borderline and malignant. Bilaterality is common in serous tumor and samoma bodies are a characteristic feature of serous tumor. So serous carcinoma is the most common malignant epithelial tumor. So mucinous tumor have got cells which have got abundant mucinous cytoplasm. The commonly it is benign or borderline. Malignant mucinous carcinomas are very rare. So these are the references. Thank you.